Hi, everybody. This is Chris Joseph, and I'm here with Dr. Amy Neff. Hi, Amy.
Hey, Chris. Good to see you.
Good to be talking with you and seeing you on Zoom. We're here, I guess, to talk about what we do.
What do we do, Chris?
What do we do? I hopefully, as we've talked about before we hit record, we can make this conversational. So I'm going to ask you, I'm going to interview you here for a minute.
I love it.
Tell me what you do and how you got into this space.
Gotcha. So I'm a started as a family medicine doctor, trained in integrative medicine, trained in psychedelic medicine. And in the course of my training in psychedelic medicine, my husband got cancer. And so we just naturally, because he's a doctor too, we did a fellowship of our own making in rectal cancer. And as I was learning, I came across Nasha Winner's course and took it. And that's how you and I met. Um, and so since I've taken the course and, actually consistently through my time of like providing integrative medicine services, I've worked with cancer patients. The kind of alpha patient number one being my husband. Um, and in the course of that, what I've learned is how challenging it is to navigate the world of being a patient as a cancering person, and then also the world of being a caregiver, or support person to someone that's cancering. Um, so at this point, I work with people with cancer diagnoses, and I fill the role both as patients that are avoiding standard of care options, and then also fill the role of working with people's oncology team. I don't have a strong feeling about that.
So were you trained originally on standard of care and standard of care?
So in terms of standard of care oncology, no. So that's a fellowship. Patient or doctors that provide oncology services are hematologist oncologists, and they're trained, in medical oncologists are trained in the provision of typically chemotherapies for cancer. And then there are radiation oncologists that are trained in using radiation therapies. And there are surgical oncologists who are trained in the use of surgery to treat cancers. And so kind of like those three different providers form the basis of the standard of care approach. And people that are cancering would still have like a primary care doctor. And
Mhm.
that's the role that I play in most people's lives is as a primary care doctor.
So as you've experienced what you experienced with your husband and in your practice, what did you think, or or how did you feel when you started to learn about all these other alternatives that are available to
Right.
people?
Um, well, frankly, I felt overwhelmed.
Mm.
Uh, I mean, if I'm honest, the first, feeling, and actually, I mean, if I kind of zoom back out, what I can tell you is that, 5 years ago or more, a member of my community, like, not a friend, but someone that I knew kind of like in my neighborhood, came to see me as a patient at my integrative medicine practice, and he said, I have lung cancer. And he pulls out this book by Jane McClellan, and it says How to Starve Cancer. And he hands it to me and he says, would you please read this? And and that's really where my awareness of all the things that can be done started. Because in my mind as a primary care doctor, it's like prescribe Cimetidine, an over-the-counter like acid blocking drug for cancer? Of course I would, if it helps, if it has the possibility of helping. Prescribe metformin? Of course I would, you know, like I have zero heartburn about that. Um, and and I think that honestly, a lot of that disinhibition in my case comes from the fact that 10 years in the first part of my career, I ran a free clinic. And so I just literally was like, I mean, the people that I was taking care of, including people with cancer, I was the expert in everything. And if I didn't have the courage to do something, they just wouldn't get it. And, so I think that I'm very much like worn down on fear. I don't have it clinically when I take care of people. Um, and that's something that I notice in the standard care oncology world. Like when we were talking with, my husband's care team about using lithium as a radiation sensitizing agent, based on a paper written at Vanderbilt where we're getting our care. And the radiation oncologist is like, I don't know anything about that,
Mm.
period. You know? And I'm like, you're not going to read the paper? Like you're not even willing to try? And and it was shocking to me. It was painful. Um, and so that's when I just really started to become aware of all that could be filled in, all the potential. Yeah.
It's really eye-opening, and I'll introduce myself in a minute here, but it's really eye-opening to see standard of care. I'm not criticizing. I think there's a place for it, but I also believe it's limited in some ways. It's
Yeah.
treating the tumor instead of treating the body, treating the terrain of the patient. Western medicine, for the most part, doesn't look at root causes.
Right. Yes.
And when you realize that upwards of 90 to 95% of cancers are not hereditary, they're lifestyle, environmental, that's really eye-opening.
Yes. Right.
But it also presents an opportunity, like,
Mm.
oh, okay, if my lifestyle choices help cause this, maybe changing my lifestyle choices will help cure it.
Yeah. Right. Um, and again, it's like the opportunity, right? So if I just as a regular old integrative medicine doctor start the conversation about placebo and how effective it is, right? And similarly, the word nocebo, right? Then the negative version of a placebo. If we just use those two tools in the toolkit, in cancer chemotherapy trials, placebo works 30% of the time, right?
Wow.
Why would we leave that off the table? And similarly, I mean, we'll talk about this, I'm sure, but as you know, as a patient, knowing that you are engaging every day in things that you feel confident are making you better, it's very powerful.
Without question, yeah.
Yeah. And knowing that you are doing things every day that you feel like are making you sick also has its own power.
It could be a snowball effect either way.
Yeah, right. I mean, I felt like that in the standard of care stuff, the chemotherapy or the radiation therapy that my husband got, it was kind of like that, feeling like, yes, it's probably doing what it needs to do with the cancer, but it's also hurting me. Right. And so, in our training, we've talked a lot about how can we do not the maximum tolerated dose, but the least possible dose to achieve the desired effect.
Right.
Right. Because, you know, behind this treatment is this precious soul, right? That's like gotta have a will to live. And it's really not fun to live in a body that's wrecked by treatment.
I sensed in my first chemotherapy treatment, maybe I should introduce myself
Oh,
and then I
yeah.
can.
Chris,
um,
tell us about you. How'd you
so
get here?
how did I get here? So a little over 8 years ago, October of 2016, it was actually Halloween Day. I don't know if that has any meaning or not, but it was Halloween Day. I went in to get some scans. I'd been having some digestive discomfort for a couple months. I thought it was some sort of a flu or a lingering bug. Lo and behold, I was diagnosed with third stage pancreatic cancer. Now it's probably an opportunity to tell the listeners that 70% of people diagnosed with pancreatic cancer are dead within 1 year. About 90%, I think it's actually down to 88% are dead within 5 years. So people generally mostly do not survive this cancer.
Mm,
So it's a really, really, really And I knew the statistics when I got diagnosed, and it scared the crap out of me. I mean, it's where I was going with this was I for the first 3 or 4 months I did chemo, and the first session of chemo, I remember walking away thinking, I don't like this. I can taste it. This doesn't make me feel well. It didn't make sense. It didn't make sense to me that I had to hurt myself in order to help myself. I might have been able to tolerate it. Like I said, I did it for 3 or 4 months, but it wasn't working. My
Mhm.
tumors were growing for the next few months. They upped the chemo, which made my health that much worse. Then finally, a few months, March of 2017, just 5 months after I got diagnosed, I quit chemo and I had no plan B. People, my girlfriend, my family, my friends almost universally thought I was crazy. Part of me thought I was crazy because I had no plan B. I just knew I didn't want to do that anymore, that being chemo. And I figured I'd rather die of cancer than die of chemo. That's how miserable I was. But I'll end this part of my little short presentation here by saying the day I quit chemo in March of 2017 turned out to be the best day
Mm,
because it opened up a world of opportunities that I knew a little bit about, but I didn't really know much about.
yeah.
I knew I wanted to live.
Mm,
And lo and behold, 8 years later, I'm still here and thriving. There's obviously a lot of stories on how I got from there to here, but that's the beginning of it. Now I'm here to how I got into the space. I'm a cancer coach, terrain advocate, and the number one thing I do, I think, is provide hope to people.
mm.
Provide hope.
Yeah. Can you tell me a little bit more about that decision that you wanted to live?
Yeah, yeah. Funny, I've been interviewed many, many times, and no one's ever asked me that question before. So I want to really think and be thoughtful about how I answer it. My kids at the time in 2016, 2017 were 14 and 12.
Mm,
I think my younger one may have started, I mean, my older one may have started high school, but if not, they were both in middle school. Um, I had them half time. Thankfully, my ex-wife and I, who we get along great, and she knew I needed my kids around.
mhm,
It's going to be part of my journey. She sensed that. She's really smart. And so part of it is I wanted to live for my kids.
mm, mhm,
I was so afraid that I wouldn't get to see them graduate from high school. Spoiler alert, I did. They're both in college. Um, one graduates college next year. I would say that was the number one thing that I wanted to be there for my kids.
mhm,
I just that was like a mantra for me.
mm,
I wanted to be there for my girlfriend. I wanted to continue working, and I did. I continued working through this whole process, this whole journey. I've always been really active. I've always had a lot of irons in the fire, different projects I'm working on and stuff. And I just remember thinking, I've got too much to do.
yeah.
I, I don't want to die from this. I mean, I'm not ready.
Yeah.
I could have been humbled. I could have wound up dying anyway. I mean, you don't know, right? I mean,
You
you
don't
don't
know.
know.
Yeah.
But I hope that answered your question. I just felt like I had so many things that I still wanted to do, and I still feel that way mostly.
Yeah.
Um,
Yeah. I think it's important. We talk about like in our training, we talk about people, kind of needing to cultivate this sense of mission and purpose. And, I think I have a good perspective on that being a primary care doctor, in my typical line of questions with people, like, what do you do for fun? And what brings you meaning? When
mm,
people struggle to answer those questions, it's to me, it's just a great direction. It's like, oh, well, there's our work, right? We start there. Um,
we start there. I know you know about Kelly Turner's book, Radical Remission. If the listeners
Mhm.
don't know about that book, it's one of the top maybe three books I recommend people
Right.
to read. And it's basically Kelly Turner is a researcher, PhD researcher, and discovered that there were 10 factors that help people, what she called radical remission. I don't really think it's all that radical anymore, but I think it's more normal than we know,
Right.
more common than we know. But
Mhm.
one of the 10 factors that she studied was having a strong reason to live.
Yeah.
I had not read her book when I got diagnosed. I've only read her book in the last couple of years. Um, but she's right.
Right. It's so funny that you say that, Chris, because I think by the time we were in the cancering space, my husband, he read Radical Remission first, and he's like, there's not much in here. Because we were already doing those things, he felt like it wasn't like necessarily adding to the mix. So what I can say is like because of some of those other books that we read before that, her-
Right. Everyone starts at a different starting point,
right,
right? I mean,
Kelly's
yeah,
really important points, had already been kind of made. And what I like about Radical Remission is that it invites us into the kind of the subtleties of what needs to change, right? The subtle kind of it's a little bit of movement, it's a little bit of meaning, it's a little bit of, nutrition and relationships and you know, it doesn't have to be maximum tolerated dose, of
it does not have to be at all. Yeah. Yeah. It's pretty amazing. I guess there was one other thing I wanted to say just as part of the intro to my journey. I was very public early on, even when I wasn't doing well. I was blogging, I was making videos. I mean, I'd get on Facebook and I'd burst into tears while I was recording, and I still posted those things. And some people I know found them very difficult to watch, and I get it. I get it. It was difficult for me to live that. So, because they were watching me being in a lot of emotional pain.
yeah.
But my point is that I was not private at all,
Mm,
and I would blog about it. I actually turned those blogs into a book in 2020. But because I was not private, when people started seeing I was doing well, in later in 2017, I started getting calls from people, mostly in the US, but sometimes from around the world. What'd you do? Tell me what you did.
mhm,
And it was really overwhelming and intimidating because I am not a doctor
uh,
and I am very mindful of that. I do not in any way comment on, I tell people my story,
uh-huh.
but I would never say to someone, and I don't say to anyone, oh, you should quit chemo or, ask your doctor about this particular Western medicine procedure. That's just not my area of expertise, and it would be unethical of me to do that and illegal for me to do that.
Mhm.
But I did back then tell my story, and I realized what people wanted was hope. They wanted hope.
Right, right. So it's so funny that you say that. I'm thinking about a couple of clients that I've worked with who I think are doing great, but they came into the system at an advanced stage. And separately, they say to me, I feel like dead man walking
Mm,
in the cancer clinic, you know, that the conversation has moved on beyond healing to just getting as much time as possible. And it's like, ah, I want and often say, like, I explain what I think a medical hex is, which is, any language that's used that takes your sense of hope away, right? And I think there's, I can hear like, you know, the medical world going like, you can't, say something to people that's not an accurate reflection. And it's like, wait a minute. I don't believe in like pie in the sky kind of things. I think we have to really just be willing to accept what's arriving, and then also to embrace our power, right? uh, which includes the potential for miracles to occur. And we might have to agree that a miracle would be kind of like what is required here. And those things happen, right?
They happen a lot. We're not told about them.
Right, right.
We're not interviewed. You know, the journey like I've had, I don't get on CNN. They're not looking.
Well, we need to change that, Chris.
Yeah, exactly. They're not looking at people like me.
Right.
I want to, I think this is related to what you were just talking about. I've had discussions with oncologists. I think when a doctor, and this is quite common, a doctor will look at a patient and tell the patient if they're too far, if they think they're too far gone, well, maybe you have 6 months to live or a year or whatever. And I think that's completely irresponsible and unnecessary. And I think what doctors should be saying is, I don't know what else I can do for you.
Mm,
Because that would be honest, right?
yes.
And then they can say, but maybe you should try another doctor or
Right.
techniques, different modalities, maybe someone in the naturopathic world. Give them hope.
Right.
Give them hope. Don't give them a death sentence.
Yes. And, again, even outside of cancer care, Chris, like people I work with, I've got a patient right now. She's in her 80s. She still works full time. And, her body's accumulated some stuff over the decades. And some of it's challenging to live with. And the thing that she has said to me, because I feel like I'm always learning, my eyes are open to all the things that could show up. She says every time I meet with her that I give her hope. you know, she walks out with some wind in her sails. I'm like, great. Now thankfully she told me that. I understand now what my work is, you know, and it's not snake oil. I'm not selling snake oil, you know,
Not at all.
but I have fully embraced the, it's, um, it is a non-human or a non-ordinary role that I've had to be willing to accept. I'm a person, I'm just Amy, right? Love my dogs. When I'm in that like doctor patient space, I have to be willing to accept the mantle of healer, not as a like a creepy religious thing, but as it's my role as the up power in that dynamic. I have power over the client that I'm working with. They have come and they've offered this vulnerability to me, sharing a story, being willing to allow me to prescribe drugs and make suggestions, right? And so, um, kind of circling back to this placebo idea, I have to be willing to put my belief in there, that um, that I feel not only that they're deserving of healing, whatever that looks like, you know, healing might not even be an extension of days, could be just an improvement in quality, which like links up with hope, right? Um,
Absolutely. Yeah. I mean, if we're living a better life, a healthier life, we can influence that. We can influence that
yeah.
tremendously. We're not told that.
Mm-mm.
We're not told that. How many times have you heard this story? And I hear it a lot where doctors will tell their patients, their cancer patients, oh, just eat whatever you want.
So I have my specific example of that. My husband, when he was diagnosed with his rectal cancer, was pre-diabetic. And so we immediately set about to correcting his metabolism. And he lost some weight. And it wasn't like a ton of weight. But when he went into, see the radiation oncologist, the nurse said to him, "Oh, honey," I mean, we are in Tennessee. "Oh, honey, you need to have extra mayonnaise on your ham sandwiches and have two desserts every day." And, he's just like, uh, okay, you know. Um, yeah, that's our specific example.
Think about hospital food and how unhealthy it is, which which makes no sense whatsoever when you step back and try to connect those dots. Like, wait a minute, they're feeding me unhealthy food and I'm trying to get healthy.
Right, right. Oh, I know. Those like I'm thinking about a good friend of mine kind of waking up from her third or fourth cancer surgery, right? In that tray. And I'm just like, "Get out of here. Put something else on that."
Yeah. I mean, I guess I know we're sort of jumping around a little bit here, but part of what I want to do and what I am doing in this space and helping people, I'm also trying to change languaging and how people look at cancer.
Yeah.
The mainstream cancer organizations, they deal in treatments and they're looking to find the next big drug or treatment modality that will nip the cancer in the bud. And they're still treatments, they're not cures.
Hmm.
My feeling is, and I know you agree, let's also look at root causes. Let's look at prevention,
Yes.
because prevention is the best cure.
Right. Primary and secondary, you know?
Mhm.
Um, totally. Well, so tell me a little bit more if you have some specifics in mind about what the language change could look like.
Yeah, I mean, it's in the media, it's in social media posts, it's pretty much in our culture. People will say John Smith is fighting cancer or battling cancer, or he lost his battle with cancer, or cancer is a bitch, or excuse my language, people will write fuck cancer. I mean,
Yeah.
and and I even from day one, I never looked at it that way.
Mhm.
It never made sense to me. I mean, why do I want to battle my body?
Right.
I'm trying to heal. Battling it takes a lot of work. It's a
Yeah.
lot of energy. I need my energy to heal.
Yeah.
So the language never resonated with me, nor do I think I now I look at cancer. Cancer gave me an opportunity. Cancer, the cancer in my body was sending out warning signals, something is wrong,
Mhm.
and you have an opportunity to deal with it,
Yeah.
fix this. So I know it might sound weird to some people, but I look at it as an opportunity.
Yeah. Well, that's kind of like the in the stages of grief, you know, there's like denial, anger, bargaining, depression. Well, the final one, there used to be five stages of grief, and now there's a sixth one, and it's integration, right? It's like, how did this event come into my life and serve me in some way, right? Um, essentially to come to terms with whatever it is, uh,
Mm.
that it's not a poison, or a defeat, but an opportunity, even if the event itself is unpleasant, you know.
Oh yeah, I mean, on the one hand, my life is better 8 years into this. It really is better. Now, do I wish I could have had this better life without going through cancer?
Hmm.
Of course. But that's not what was presented. What
Right.
was presented was this health challenge, and I had the opportunity to do something about it.
Yeah. Right.
Uh, yeah, and well, I guess that's another way. That's another thing to bring up, and I'm sure we'll get into this on subsequent episodes of this. But people are, like I said, people are always asking me, "What'd you do? What'd you do? Tell me what you did," and they want the quick answers and the easy solutions. And hey, there is no easy solution. There are no quick answers.
Right.
This is this is a lot of work. I
Right.
do not sugarcoat that with people. I tell them that in the first meeting with them. This is a lot of work,
Yep.
but it's worth it. And the number one thing I tell people is take charge of your health. Absolute number one thing. Take charge of your health. You decide when a plumber or an electrician comes over, they don't just start working and then bill you. They put it together an estimate. You can get other bids. You decide what you want to do when it comes to getting your house fixed. So why wouldn't you get to decide to do when you want to get your body fixed? Um,
Yeah, I
and
say that. I use your language all the time, Chris. You know, I invite people to become the CEO of their healthcare. And that agency, that sense of agency, you know. And again, it's not to say you have to be the expert in your healthcare. You call in the team, right? You and
call in the
yeah,
you call in the team and if something doesn't sound right or feel right, you can ask people, you can ask for clarification, you can get a second opinion, you can say no.
yeah.
You can say no. I learned that by saying no to chemo.
Mm, yeah,
Like I said, the most pivotal day of this whole thing when I said no.
yeah.
I'm going to be honest about it. Like I said, it could have turned out to be a disaster. I could have died by quitting chemo and embarking on a different path. There are no guarantees.
Well, but I think what you've also said, Chris, is that you were already, it wasn't working, you know?
No, it was the scans were showing that things were growing. Yeah,
Right.
yeah.
And so sometimes, just like you've said, when someone is, kind of like at a point where Western medicine standard of care doesn't really have a lot to offer, often the response in the situation is just kind of like, oh, I get like we're done here, or they'll use things like kind of tough language like salvage chemotherapy or, you know, palliative things. And um that's it's disempowering, right? A person.
Indeed, it is. Yeah, yeah, yeah. You actually just made me think of another languaging thing that I'm trying to work on with people, and that is surviving versus thriving.
Ah,
The
yes,
cancer organizations talk about survival rates. That's not good enough.
right.
It's not, we got to raise the bar. It's about thriving, not just surviving.
Right. Well, especially when survival, some of the statistics, for certain tumor types, like a major win, 50% increase in life expectancy post-diagnosis, and that 50% increase is 2 months,
Right,
right?
right, right, right.
And it's not two good quality months, you know. Those are the things that just if like can't we just speak plainly about it, right? Openly, plainly. And I think that in that pipeline, right, again, from a patient perspective, and here I am, like I'm a physician, my husband's a physician. When we're sitting in that room and we've been given like, 20 minutes, 30 minutes to digest the diagnosis, and then it's like, and we're going to get your port put in, and we're going to get this. And you're walking out with like a packet, and you've met with a pharmacist, and, you know, they kind of, it's like, I just kept feeling like, oh, we're being bamboozled here, and we're going in. Um, yes, and so is there a way, I mean, I've actually gone with some of my patients to their oncology appointments. Just as I mean, I'm not, I don't obscure who I am. I'm like their advocate in that setting. Just to kind of slow it down and be able to kind of ask the right questions. Um, because if a provider only says like this doubles your life expectancy to do this treatment, but they don't add to it that it's not much time and the side effects are um untenable. And as you and I've learned through our training, it's like, and sometimes you're not even a good candidate for the treatment. You're either too sick or like a treatment that requires your immune system to respond. If you have no functioning immune system, like not going to work for you.
Yeah, they're working off the one size fits all model.
Right, right. And so again, it's like right patient, right treatment, right time. And the system, again, I don't think the people in the system are bad. It's just that the system doesn't have time to kind of do those things. And there's no reward right now for discernment. But patients deserve that. Um, and so that's where you and I come in, right?
So there's one other thing I want to bring up, um, and that is something. It's a word, a term that is triggering to probably almost everyone. But in the way I'm going to say it, after I say it, I'll explain why it's not going to be triggering,
Okay.
and that is COVID.
Mm,
Now, I'm not going to talk about masks or vaccines or lockdowns or anything that is controversial because that is triggering to almost anyone or everyone. But the reason I bring up COVID, and I bring this up to every patient I work with, is because COVID shined a light on how unhealthy this country is.
yeah,
And unfortunately and sadly, people who are vulnerable, who had pre-existing conditions, were very vulnerable to the virus and had very poor outcomes. And that's horribly, horribly sad.
right.
But we didn't take, as a society, as a populace, we didn't take the opportunity to really do anything about how unhealthy we are. That's what I'm trying to do. I think
Yes.
you're trying to do. I'm just trying to get people healthier.
Right. Well, I mean, it's at the end of the day, to me, it's about well-being. It's about how you actually feel, and we can kind of like remove all of these things. Again, I'd be curious to know your experience, but cancer diagnosis, it feels like task, 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 right? And when we get into those like very task-oriented like spaces, we stop living, we stop thinking about how we're feeling, and so, um, kind of circling back to before we started recording the words you used about gratitude, right? Pausing, noticing, you know, allowing, and then as best you can, kind of cultivating a sense of gratitude for what's here is a big part of this life well lived.
So important. Thank you for bringing that up again. It's so important. Um, I was on a call with my older son who goes to college in Europe, and he was telling me about his school, and we were talking about politics. He lives in the Netherlands, and there's been some civil unrest the last few days, and we were talking about that. And I hung up after about 45 minutes, and I just felt
Mm,
so grateful talking with him and connecting with him and hearing that he's really doing well in his life. Um, and then, yeah, I just kept thinking, I'm so grateful. I mean, some of it's luck, right? Some of it's luck, but some of it is what we do with what's in front of us too. So,
right.
uh,
Oh yeah. No, this is a common theme, Chris. Like it feels like the kind of the theme of wisdom in my decade of my life, which is when something either makes me feel bad or makes me feel good, you know, those are things that at this point in my life often are attached to some kind of sacrifice. Like it makes me feel
mm,
good to eat properly, which is not indulgent, right? It makes me feel bad to do things that, make me feel bad, drink alcohol or not exercise or quit offering gratitude. And so the wisdom says, are you willing to do these things that make you feel good? Or are you willing to stop doing these things that make you feel bad? And if there are barriers to that, like, well, can we just talk about that? Can we can we come to understand that?
yeah, or that may make you feel good in the moment, but a half hour later, don't make you feel good. Uh,
Right. Yes. Well, that kind of like clarity on what good is, right?
yeah, yeah,
Which is
yeah, yeah.
different from euphoric,
Yeah.
it's from many things. It's
I think we should save well, we will definitely have subsequent talks here, but how to get healthier. I think we should save that for
oh yeah.
another another episode. But I did want to say one other thing. When I do teach people how to get healthier, I know you do that too as part of your work. There are no side effects from getting help.
Right, right.
None.
None, none at all.
Um, and we can't say that about medicine and surgeries and virtually every Western medicine procedure.
Right. Well, and I think what you're also saying is although there are no side effects, the medicine can be bitter, can be a bitter pill to swallow to change.
It can.
It
It's
can.
hard.
It is hard. And people often ask me, and again, I work with people like across spectrums, not just in cancer, and they'll ask me, like, do I need to do this? And I'll always say, well, at the end of the day, we're dependent on your inner healer, right? Like to help us understand what you need to do and what's most important. So someone with metabolic syndrome, liver disease, for instance, that definitely needs to change how they're nourishing themselves. We talk about how high are the stakes if you don't change, you know? And then also, frankly, like, point blank, I look them in the eye and I'm like, do you think you need to do this? And if they come back at me and they're like, yes, I do. I'm like, well, okay. The inner healer has spoken, right? If there's a lot of ambivalence or lack of clarity, it's time to, kind of like explore that more. And I think that a great example for that is, the question about a ketogenic diet and cancer. You know, it's something, again, that I think that for a lot of people, it can be beneficial. It can clearly kind of mop up a lot of glucose regulatory things, but it might not be for everybody. And and so I'm no more going to say like there's only one way to do it, right? Then I mean, because I think that's anti-therapeutic. It's you're the CEO, right?
We are our own CEOs. One of the joys of working from home is I have a barking dog, which I don't know if you can hear.
Not at all. I have
Usually that
family in the kitchen, so it's like it's great. It's all good. Yeah.
usually it means an Amazon truck or a UPS truck and stop to drop something off, and my dog goes crazy.
Yeah.
I do think we should maybe wrap this up for
Yeah.
this. We have so much more to talk about.
We
So
surely do, right? And and just to kind of like give a flavor of what might be to come. So we talked about what you do as an advocate and your own experience of being a patient. I've talked about myself as a physician and, you know, also caregiver, and so we have these personal experiences of cancering that I think inform a lot of what we do and why. Certainly kind of have filled the reservoir of how complex it is to greet these diagnoses. It's not like cut and dried. It's everybody has their own experience. And and our role is to nourish that experience, empower it.
I think one of the things that we want to also define, and maybe we can do this in the next episode, is what does metabolic syndrome mean? What
Oh,
is the metabolic approach?
yes. Oh, yeah. There's so much there.
And why are upwards of 90% of people in the United States not metabolically healthy?
Right.
Not a criticism, just
No.
that it just is what it is.
Yeah. No, I think that's a great place for us to start next time.
Okay.
And um and then, we're also going to unpack like how do we work together? Like what's the difference between your role and my role? How do we work with other clinicians, Um and so, kind of inward facing, outward facing, and cultivating that voice that each patient has and needs in order to kind of move through this. Another one of my favorite things I always ask patients is typically they're showing up in one of three places, and patients are going to differ every time. They might need to collapse. Like sometimes everything's just really heavy and they just need a place to come in and really fall apart. And our society doesn't love that. There's not a lot, it like scares people. I think you were describing some of that, like with some of your communication early in your diagnosis. Like they can't handle those emotions. So I offer people that space to like come and collapse. Sometimes people come in and they're like, I read something and I just need to know if it's cool, you know? And then sometimes people come in and they're like, I am flying and I just need you to like see it and throw a little energy towards me. Um, and that can change moment to moment, really. Like,
Love that.
yeah,
Really love that. Chronic illness can be such a lonely journey. It really can be a lonely journey. I mean, I experienced that firsthand. Um, I don't know if it has to be. I don't know if it has to be. I think the more we share, the more we show ourselves to other people, that we can lower the temperature on that a little bit.
right, right. So weaving that in, the loneliness of being the patient, right? And I would reflect on that too, that there's a loneliness in being a caregiver.
Without question. Boy, we can talk about that in one of the subsequent episodes. Just how valuable caregivers are and how much stress there is on caregivers.
Yes.
I mean, you're experiencing this world from being a caregiver in your home and also a caregiver in your work.
Yes.
Uh, and
Uh-huh.
that's a lot.
Yes.
So one of my questions that I don't want you to answer now is but for you to think about is how do you take care of yourself?
Mm. Oh, yeah. No, I ask myself that all the time because my number one rule of parenting was always um, make sure that you have enough in your tank so that you are not making people feel guilty about, the receiving, you know, that just necessarily comes from the role of parenting. Um, it's a thing that we owe to the people receiving.
Absolutely.
Yes.
Can I tell one last story? Then I think we really should wrap this up.
Sure, I love
So, woman I've been involved with for the last 12 years. So this was in 2016. Susie is her name. She would come with me to most of my doctor appointments, and really, that's another tip for people: bring someone with you and have them take pieces of paper and a pen and have them ask questions. I mean, there's so many little tips for people, but there was one doctor appointment early on when my doctor was telling me I wasn't doing well. The chemo wasn't working. The scans were showing the tumors were growing. And out of the corner of my eye, I'm watching Susie, and she broke down.
Uh-huh.
And it was the first time I'd seen that. And it was, on the one hand, it was, oh my God, if she's scared, what does that mean, right?
Yeah.
What does that mean? Because I was scared too, of course. But on the other hand, it was really one of the most human moments because she really she showed me, I knew she cared about me and loved me, but it was really to see that. It was actually a really beautiful moment,
Uh-huh.
really beautiful moment that she showed that. Um, it really taught me a lot about caregivers. I've really never been one.
Uh-huh.
Uh, I've only been on the patient side. So I guess I'm a caregiver in my work now, but I mean, just in terms of having a loved one,
Yeah.
having a love, um,
Oh yeah. I know we'll talk at some point about death, right? And one of my favorite kind of spaces that I more philosophically operate in is the world of psychedelics and end of life. And Roland Griffiths, who was a psychedelic researcher, recently died of metastatic cancer. Knew that he was dying and talked a lot about the dying process. And he talked about how psychedelic dying is. But for caregivers, it's not. It's not, like the body is doing all of these things, kind of like priming our consciousness with end of life experiences that are very psychedelic. And I think that for the people that, have used psychedelic medicines therapeutically, they sense that they have these near death experiences. Anyways, just that,
we,
yeah, we'll get there.
we, yeah, we need to add that to the list of things to talk about. I've experimented with psychedelics as well. And they can be very helpful. when supervised, they can be very helpful.
Oh, yes.
Um,
Set and setting, right patient, right time, right medicine. Yes.
I love that. I'm going to write that down. I now know who is knocking at my door, so I'm gonna bow out here.
Right. It's
Um,
time. Well, Chris, until next time, I'm looking forward to it. We have so much to talk about.
Love this. Thank you so much, Amy.
All right. Take care. Until next time.
Okay, bye-bye.